What is going on, guys? Josh here, back with a video on blood testing for metabolic health and diabetes. Before I get started, please be sure to subscribe to the channel, like the video, and leave a comment when you finish watching if you enjoy the content. As you can see, I've got a little bit of an upgrade for the studio. I think it looks pretty nice. Let me know what you guys think. It's going to be a work in progress. In my previous video, I mentioned the lab tests I think everyone should be getting at different times of the year, from once a quarter to every 6 months to annually. In this video, I will cover in depth the different types of diabetes, as well as the major tests that you can use to track your glucose metabolism and checking if you are at risk for diabetes, or if you have diabetes, how to monitor it while you treat. To frame this properly, we first need to discuss the difference between type 1 and type 2 diabetes. Globally, 1 in 11 adults has diabetes mellitus, 90% of those having type 2. Let's start off with type 1. We'll cover what that is, and then we'll move on to type 2. Type 1 diabetes. Type 1 diabetes is, generally speaking, an autoimmune condition where little or no insulin is produced by the pancreas. Insulin is a protein hormone and is produced by what are called the beta cells in your pancreas, the most common type of islet cell in the pancreas. The inability of these beta cells to release insulin in type 1 diabetes is caused by a chronic inflammatory process. The onset of type 1 gradually increases from birth and peaks at age 4 to 6 years, and then again from 10 to 14 years. For reference, the prevalence in people under age 20 is about 2.3 people per 1,000 people. While most autoimmune diseases are more common in females, there are no apparent gender differences in the incidence of childhood type 1 diabetes. Now for type 2 diabetes. In type 2, an imbalance between insulin levels and insulin sensitivity causes a functional deficit of insulin. The inability for insulin to perform its job properly in managing your glucose is called insulin resistance. Insulin resistance is multifactorial, but commonly develops from obesity and aging. Type 2 involves a more complex interplay between genetics and lifestyle, but there is a clear evidence suggesting that type 2 has a stronger hereditary profile as compared to type 1. Generally speaking, is more likely to be passed from generation to generation. The majority of patients with the disease have at least one parent with type 2 diabetes. Typically speaking, folks that acquire type 2 diabetes have been eating high carbohydrate, including sugars, for a long period of time, may or may not exercise, and these two things combine with genetic factors to create that insulin resistance, meaning reduced effectiveness of insulin against the free-floating glucose in the blood, which causes type 2 diabetes. While type 1 and type 2 can present similarly, they can be distinguished based on clinical history and examination. Type 2 patients are typically overweight or obese and can have velvety patches on their neck. Patients with a longer course of hyperglycemia, meaning elevated glucose in the blood, may have blurry vision, frequent yeast infections, and numbness or neuropathic pain. For those with type 2 diabetes, or who have deficiency or insufficient activity of insulin, these individuals typically do not need insulin treatment to survive, but may require insulin treatment if the condition is advanced enough. Next, we have another category of diabetes called MODY, mature onset diabetes of the young, or MODY. MODY is a heterogeneous disorder identified by non-insulin dependent diabetes diagnosed at a young age, usually under 25. It carries a autosomal dominant transmission and does not involve autoantibodies as does type 1. MODY diabetes are characterized by impaired insulin secretion with minimal or no defects in insulin action. Monogenetic defects that cause beta cell dysfunction, including MODY, represent a small but important fraction of patients with diabetes, roughly about 5%. Lastly, there is something called gestational diabetes. Gestational meaning during pregnancy. Gestational diabetes occurs when a woman's body can't make enough insulin during pregnancy. Although most cases resolve with delivery, As an ongoing epidemic of obesity and diabetes has led to more type 2 diabetes in women of childbearing age, the number of pregnant women with undiagnosed type 2 diabetes has increased. Approximately 7% of all pregnancies are complicated by gestational diabetes, resulting in about 200,000 cases annually in the US. Finally, there are other possible causes of diabetes, but these are the primary categories. Now, for the lab tests you can get to help prevent, manage, or track healthy or poor glucose metabolism and diabetes. Fasted glucose. A normal or healthy fasted glucose might be between 60 to 99 milligrams per deciliter. A pre-diabetic might be considered between 100 to 125 milligrams per deciliter, and anything over 126 is considered diabetes. If you have a fasted glucose of above the low 90s, you should consider reducing your sugar intake and perhaps adding in intermittent fasting if you can tolerate it. I don't really think it's all that hard. Confine all of your eating to a specific window. So let's say you eat all your food within a 6 or 8 hour window, and then you don't eat anything for a 16 to 18 hour window. I know it sounds like a lot because most of us have 3 meals a day, about 6 to 8 hours apart, but trust me, it is doable and it can really help bring down those fasted glucose levels. So for example, if you eat all your meals between 12 p.m. and 8 p.m., you are not eating for 16 hours after 8 p.m. to the following 12 p.m. That time without eating gives your body time to burn through the excess glucose that you have in your bloodstream, brings down that fasted glucose number. Intermittent fasting can be very good for your metabolic health. Next, fasted insulin. The lower the better. This means that your system is replete of glucose in the bloodstream, meaning if you don't have excess insulin in your bloodstream after a fast, your body is efficiently burning through using glucose. For example, when you're not constipated, you know that things are moving efficiently. When you have too much glucose in your blood, it's a bit like being constipated. Things stop working quite as well. So an ideal fasted insulin might be in the range of 4 to 8. The official ranges for diabetes on fasted insulin tests are under 19 for the ECLIA method, under 24 for immunoassay. These are different methods that the labs use to conduct the test. And you can tell what kind of method your test uses by looking at the lab order or by asking your physician. So when you're referencing these numbers, make sure you know which methodology your test is using so you can accurately compare your numbers to those reference ranges. Next, hemoglobin A1C. Hemoglobin A1C, an optimal range is between 4.7 to 5, although it can vary for each person. Normal overall would be considered below 5.7, and then a range of 5.7 to 6.4 would be pre-diabetic, and anything above 6.5 is considered diabetes. Keep in mind, if you have an A1C above 5.6, you're not only at an increased risk for diabetes, but also cardiovascular disease as well. Very important that you monitor this. An elevated A1C indicates glycation or attachment of sugars to cells and tissues, which is what causes all of the terrible outcomes of diabetes you hear about, like eye damage, cardiovascular disease, neuropathy, amputations, all of that terrible stuff. Next, the AGTT, or oral glucose tolerance test. The ADA recommends that all pregnant women not known to have diabetes undergo a 75-gram AGTT at 24 to 28 weeks of pregnancy. The glucose tolerance test is a medical test in which glucose is given and blood samples are taken afterward to determine how quickly it is cleared from the blood. The AGTT should be performed in the morning after an overnight fast of at least 8 hours, and the diagnosis of gestational diabetes is made when any of the following plasma levels are exceeded. Fasting AGTT in pregnant women, anything above 92 milligrams per deciliter while fasted. After 1 hour, anything above 180 milligrams per deciliter. And after 2 hours, anything above 153 milligrams per deciliter. There are some limitations of the AGTT, however. Basically, the AGTT can't differentiate between insulin resistance in the body in general and the ability of your pancreas to create the insulin. So it's more just a general test for how does your body handle the glucose. For mature onset diabetes of the young, you want to look at the following tests: C-peptide, hemoglobin A1C, a couple of different antibody tests: GADA, G-A-D-A. Number 2, islet antigen 2 antibodies, 1A and 2A, and zinc transporter 8, or ZNT8. Of course, there are a variety of different reasons why one can get mature onset diabetes of the young, so those are just jumping off points, and you're going to want to work with your physician to get to the bottom of that. As I said, this is a very small percentage of diabetes cases, and it's typically genetic. Those cases are a bit more complicated. Finally, treatments. Since type 1 diabetes is a disease primarily due to the absence of insulin, insulin administration through daily injections or an insulin pump is the mainstay of treatment. In type 2 diabetes, diet and exercise may be adequate treatment, especially initially during the early stages. Other therapies for type 2 diabetes may target insulin sensitivity or increase insulin secretion by the pancreas. Drugs may include metformin, alpha-glucosidase inhibitors, and sodium glucose transporter 2 inhibitors, or SGLT2 inhibitors. Typically speaking, metformin is the first line of prescribed diabetic medications, and it works by lowering your baseline levels of glucose as well as after eating. Insulin administration may be necessary for type 2 patients with inadequate glucose management in the advanced stages of the disease. So only for advanced type 2 diabetes would insulin injections be necessary in the case of type 2 diabetes. In morbidly obese patients, bariatric surgery is a possible means to normalize glucose levels, and it's recommended for individuals who have already been unresponsive to other treatments and who have significant comorbidities, so meaning other health issues. If you have type 2 diabetes and it's not really advanced, depending on the cause, you may be able to reverse it. More exercise, significantly cutting carbohydrates down to, let's say, 50 to 70 grams per day. You're going to want to use a scale for that. Refer to whatever container you get your carbohydrates from. Measure it out, get a scale, and keep it to 50 to 70 grams per day, which is pretty low. It's not nothing, but it's low. And sticking only to complex carbohydrates like brown rice, you can also work with a nutritionist or physician on the exact number for you, as well as doing intermittent fasting may be just what you need to actually reverse your type 2 diabetes. There is a book on the subject called The Diabetes Code, and that covers this whole process more in depth. For mature onset diabetes of the young, or MODY, treatments for this can vary and will take too long to cover in this short video, so please be sure, as always, to consult with a qualified health practitioner, as is the case with everything you're hearing in the video. Lastly, for gestational diabetes, initial treatment of gestational diabetes is diet and exercise. If that fails, metformin can be tried, and then failing metformin, temporary insulin can be used. Alright guys, well that's it for this video on the background of the different types of diabetes, as well as the testing, optimal ranges, and treatments. I hope you guys enjoyed the video. Remember to like, subscribe, share, and comment. Help your boy out. And I will see you guys in the next video. Take care.